Good morning, everyone. Big welcome to the Long Gallery here at Parliament Buildings for our seminar on reducing alcohol harm in Northern Ireland, the potential for minimum unit pricing, hosted by the Institute of Public Health on behalf of the North-South Alcohol Policy Advisory Group. I'm Jo Scott, and I'm delighted to be moderating today's session. I'm looking forward to hearing presentations from our experts, followed by what will hopefully be a lively and engaging panel discussion later. Before we begin, though, I'd like to hand over briefly to the CEO of the Institute of Public Health, Suzanne Costello.
Thank you, Jo. I'm just going to briefly say a few thank yous, but firstly, welcome everyone on behalf of the Institute of Public Health. It's great to see so many people here today. Really appreciate it under the circumstances of the weather. We would particularly like to thank our sponsors of this beautiful room, David Brooks, Deborah Erskine and Colin McGrath. It's a real privilege always to be in Stormont, and it's lovely to be here today. I hope that all of you who've made the effort to come today will really enjoy this presentation. I think by anyone's standards we have an exceptional gathering of experts in the room, both on the panel and in the audience. So I think that will really inform the discussion that we have later, and I hope it'll help people progress their understanding of MEP, which is such an important measure in terms of reducing alcohol harm, but also other issues, broader issues of alcohol harm. So I hope you can participate in the discussion and enjoy the issues that arise today. Thank you very much.
Okay, thank you, Suzanne. So let me just start by saying that the Minister was very much looking forward to joining us this morning, but is unfortunately unwell and sends his apologies, and we of course wish him a speedy recovery. So we've got a packed programme for you this morning, and I'm delighted to be joined by a panel of leading academics, clinicians and addiction experts from across the UK and Ireland who are here to share their knowledge and their experiences in discussing how minimum unit pricing, or MUP, as we'll refer to it, could save lives and reduce levels of alcohol harm in Northern Ireland. If you'd like to post on socials this morning, we'd really encourage that. The hashtag, I think it's on the screen there, is IPHMUPNI. And remember to pop your phones on silent. So we've got presentations today from Colin Angus, Senior Research Fellow from the University of Sheffield, Dr Roger McCrory from the Royal Victoria Hospital Liver Unit, Alison Douglas, Chief Executive of Alcohol Focus Scotland, Alex Bunting, Group Director of Therapeutic and Wellbeing Services at Inspire, and Dr Joanna Purdy, Public Health Development Officer at the Institute of Public Health. But first, to kick us off, let me welcome Bill Stewart, Lead Statistician at NISRA. Bill is currently the Principal Statistician for the Public Health Information and Research Branch. He oversees population health work, supporting public health policy development through managing key health surveys, including the Northern Ireland Health and Social Care Inequalities Monitoring System. Bill also contributes to the Department of Health's Substance Use Strategy and other public health initiatives. So a very warm welcome, Bill.
Thank you very much. I had the whole bit sort of planned to introduce himself, but that's sort of done for me. So I'm Bill Stewart. I wouldn't call myself a lead statistician. I'm a principal statistician. There's many of us in the Department of Health, and I'm seconded from NISRA. So we a lot of NISRA people work in various departments. So today I'm going to take you through sort of some of the headline figures from from the Health Survey Northern Ireland, the Young Person Behaviour and Attitude Survey, and also the Northern Ireland Health and Social Care Inequalities Monitoring System. And so there's alcohol elements to all those pieces of work, and they all sit within my branch, FIRB, or to give its full title, Public Health Affairs and Research Branch. I'm good at changes, all right. So first of all, some figures from the Health Survey in Northern Ireland. Basically, the Health Survey is an annual survey. It gets around 3,000 to 4,000 sort of respondents each year, covers a wide range of health topics, and every year it alternates between a longer and a shorter module on alcohol. So some of the stats then. So I say this will probably be a very quick run through. So I apologise if I go too quick, but we've given you a handout as well. So hopefully you can refer to that and I'll give you some of the questions. Anyway, in 2023, in the Health Survey, we found that just over 3/4 of adults reported that they drank alcohol. And you can see across the graph there that it's pretty much fluctuated between around 4/5 of the respondents and hasn't really changed much. When we split it down by sex, we can see that it's 81% of males were drinkers, slightly higher than the 3/4 of females. And we also asked them about the frequency of drinking, and almost half of males drank alcohol at least once a week, and that compares with a third of females. Also, if you don't want those figures, I haven't put them up there, but they're by deprivation quintile. 82% of those in the least deprived areas drank alcohol, and that compares with 75% of the most deprived respondents. And also, in terms of drinking frequency, it was higher in the least deprived areas with 45% compared with 35% in the most deprived areas. Okay, so we asked respondents whether or not they have drank in the last 7 days. Now, this was last asked in 2019-20 because of coronavirus. We were very limited in what we could ask. So around 3 in 5 adult drinkers reported that they have drank in the 7 days previous to being surveyed. Males were more likely than females to have drank alcohol. And similarly, those in the least deprived areas, 70% were more likely to have drank alcohol in the last 7 days than those living in the most deprived areas. But you can see from the chart there, also in quintile 4, it's fairly high. So there seems to be in the more affluent areas, they're sort of they're more likely to have drank within the last 7 days. So we looked at this is where I'm going to get tongue-tied, but the recommended weekly drinking limits. I don't know, Gary's here in the audience, so you can probably correct me. The CMO guidelines anyway, which are 14 units for both males and females a week, would be the recommended level. And we asked, whether or not they drank above the response, whether they drank above it or not. So we can see from the chart that there's been a steady decline over time for both males and females, from 37% to 25% for males and 15% down to 9% of females. But there's still quite a gap between males and females, males are much more likely to have exceeded the limits. And we also ask those who drank in the last 7 days how much did they drink on their heaviest days drinking, and we can see there that nearly 2/5 of males consumed up to 5 units in their heaviest day drinking, and that compares with 3/5 of females. But maybe more concerning is that 1/5 of males who drank in the last 7 days consumed more than their weekly limit in that one day, and that compares with just 4% of females. Okay. So we also look at those who state that they don't drink. And we see just under 1/4 of respondents stated that they currently don't drink. Around 3/5 of those have never drank. So we asked in 1920, I think it was, the reasons why they chose not to drink alcohol. So those who have never drank, the main reason was they don't like it, which is not surprising. But also a further 1/4 didn't drink due to religious reasons. And again, not surprisingly, when we asked those who used to drink why they no longer drink, the main reason they gave was health reasons. But I find it quite interesting that 20% of them don't like it. Why did they drink in the first place? I don't know. But there you go. That's just me. Okay, so that's the health survey. So we'll move on to the Young Person's Behaviour and Attitude Survey, or YBAS as we call it. We like to use our acronyms in statistics, which and you always branch into them, so whatever. Anyway, the YBAS is a survey, skills-based survey. All government departments have an input into it. It's asked generally every 3 years, and and so it covers a wide range of different topics, health topics included. And it's really, I think generally you get about 78,000 respondents split over 2 separate versions of the questionnaire. So it's quite a healthy response rate to it. But again, you're relying on young people, sort of in the responses. So you get some very unusual results where they sort of, I drink 1,000 or something like that, but that's being young, isn't it? I also should say it covers years 8 to 12. Back in my day, that wasn't years; it was first year and whatever. But show me age again. But it's 11 to 16-year-olds essentially. And again, there was a link there to the publication. So we asked all the young people, sort of whether or not they've ever taken an alcoholic drink, and we can see encouragingly in the first YBAS survey there was 3/5 had stated that they had consumed an alcoholic drink, and this had halved by the latest survey in 2022. The only one thing I would note is that the last 3 surveys have been pretty consistent, so there hasn't been much change. If we look more in depth at the 2022 sort of figures, boys were more likely to have drank alcohol than girls, and then, not surprisingly, as you move up to the school years, the proportions increase quite steeply. Of those who've had an alcoholic drink, up to 2/3 of those in year 12. There wasn't any difference by deprivation area. So, of those that have drank alcohol, we would then ask them, have you ever drank so much that you've become drunk? And again, there's been a decrease over time from 61% in 2000 to 46%, but you're getting the same effect where it's sort of plateaued in the last 3 surveys. We also asked them how many times they have been drunk. A fifth had said they were drunk on 1 occasion, 12% 2 to 3 times, and 16% 4 or more times. I've summarised it 4 or more times, but we do those are more than 10 times, I think, as well. We look at that, but it's so I could get these figures for you if you want at some point. Right, that was a quick run through of that. So when I move on to the Health and Social Care Inequalities Monitoring System, essentially the Inequalities Monitoring System is a collection of various public health and health related indicators. It covers things like morbidity, mortality, service usage, cancer incidence, various things. But anything we can basically get our hands on, which the data fits. So it's a secondary analysis of existing administrative data, and so it's very much just a census for each of those. So there's just a drill down by geographic area, and it's a great tool for literally reporting indicators by geographic area, by gender, by age, etc., whatever. But the main thrust of the report is looking at the inequality gaps between the most deprived and least deprived areas, and also rural and urban areas. So there's difference. Okay, so there's two basic indicators. There's the 2 indicators which are alcohol related, which currently sit in the inequalities monitoring system. So the first one would be the standardised admission rate for alcohol related causes. So this is based on day cases and inpatients, and excludes regular attenders to hospital. It's also alcohol-related, where there's an alcohol-related cause in any of the primary or secondary diagnosis fields. We count them in this. So the admission rate, you can see, for example, in Northern Ireland in 2016-17 to 18-19 was 669 admissions per 100,000 population. And by 2021 to 22-23 had it decreased to 517 admissions per 100,000 population. So we've marked this as a decrease rather than because we generally like this sort of in the health and inequalities monitoring to indicate where there's been improvement in health outcomes, but due to the nature of these service provision sort of things, especially since COVID, where we saw real differences, and we now just refer to them as basically decreases. We're not making any kind of assumption as to whether this is demand-led change or it's a supply. So it sort of restricts the usefulness of that in a way, but the gap is valid. So we can see in the first year the gap is 300%. So we'd say that the rate in the most deprived areas was 4 times that in the least deprived areas. Luckily, it's a nice, simple calculation, and it works out. I didn't plan that one. I haven't doctored them in any way. And by the end of the period, the latest figures would show that the gap has slightly narrowed. So it's 3.5 times the most deprived. The most deprived is 3.5 times the least deprived rate. And you can see that slightly in the chart as well. The next indicator is the standardised death rate for alcohol-specific causes. Now, this is a slightly different definition than the alcohol-related causes. The alcohol-related causes is much wider because that includes causes which are not likely to be fatal. So this one's a slightly more sort of concentrated definition. So we can see here, again, look at Northern Ireland, 2014-18, there was 15.8 deaths per 100,000 population, and that had increased to 18.5, so we mark that as a negative change. There's also been an increase in the death rate in both the most deprived and the least deprived areas. But if we look at the gap overall, because they're all moving in the same direction, it's remained fairly consistent at just over 4 times the rate in the least deprived areas, or the most deprived areas. The thing to note about both the alcohol indicators is that sort of these are some of the biggest gaps that we see in the inequality. The other ones would be drug-related and maybe teenage births and things like that, which are consistently massively higher. So if you remember back to the first, I haven't bored you all to death, but if you remember back at the start, we were saying in the least deprived areas, they're more likely to drink alcohol, they're more likely to drink more frequently. There's no real difference between drinking above the weekly limit about deprivation, but so there's no real impact. So to get such a marked change then in the death rate and in the admission rates, sort of would indicate then, I had to look this up, there's an alcohol harm paradox. And again, I think it's the same through a lot of different countries and whatever the situation. So, and there doesn't seem to be any definitive answer as to why it happens, but there's a lot of suggestions as to why it does. Be it that it's been underreported in most deprived areas, or it's harmful consumption patterns, more harmful consumption patterns, or there's barriers to accessing health or alcohol treatment services for those in the most deprived areas, or there's a combined health challenge with alcohol being combined with obesity and smoking, and sort of or maybe it's just simply the wider determinants of health are playing a part. So various different reasons. Unfortunately, I don't know any of them, but I don't know which one is the main reason. But anyway, so that brings us to the end. So I'm sorry it's been a bit of a rush through, but again, I see by the faces, sort of either just waking up or stunned into submission. I don't know. I'm still waiting to wake up. So but anyway. So I'll just leave you with this there's the various links, whatever, but hopefully if you go through the actual departmental website, it's fairly easy to navigate through. And then there's there's my team's email, and then there's my email if you're really desperate to get an answer. I'll just pass it on to my team, so pretty much. And so I'm happy. I don't know what the administrative arrangements are, whether we can share the presentations or not.
Yes, we can share them.
Yes, I'm more happy that that's shared. But thank you very much. So thank you very much.
Thank you so much, Bill. Yes, there is the handout as well, and I'm sure Bill will be around later on if you want to pick his brains, but certainly a huge amount of data to process there, but thank you so much for your statistical insights and context for what we're discussing today, Bill. Next up, Colin Angus, a Senior Research Fellow and Lead Alcohol Policy Modeller in the Sheffield Addictions Research Group, which is one of the world's leading centres for alcohol policy research. Colin's work has played an important role in policy and legal debates about alcohol pricing policies, particularly MUP across the UK and Ireland and internationally. So please welcome Colin Angus.
Thank you. So Bill's given us a good sense of what alcohol harm looks like, and in particular the significant, the high level of it and the significant inequalities that there are in that harm. And so I'm going to talk now about minimum unit pricing, a policy with the potential to maybe do something about that. So this is a very MUP 101 I'm going to go for here. Okay, so what is it? Well, a minimum unit price is basically it sets a floor price, a minimum level below which you cannot sell a fixed volume of alcohol, for example, a unit. So Scotland introduced an MUP of 50 pence per unit in May 2018 and has recently legislated, or last week has it actually increased? Next week is actually going to increase, but it's legislated already to increase to 65p a unit. There we go. The Republic of Ireland introduced an MUP of €1 standard drink, which is equivalent to around 67 pence a unit in 2022. So what does that mean in terms of actual prices of real products on the shelf? These are just some random pictures I found on the internet of some indicative products here. So we've got 500ml can of 4% lager, 750ml bottle of 12.5% wine, 700ml bottle of 40% vodka, and a 2.5 litre bottle of 7.5% cider. And we'll just see how minimum unit pricing would affect those. There we go. So the can of lager has 2 units of alcohol. So at 65 pence, just to use as an example, that's £1.30. The bottle of wine, 9.4 units, that's £6.11. So that's saying you couldn't sell a 750ml bottle of wine at 12.5% for less than £6.11. 700ml bottle of vodka, 28 units, that's £18.20. So these prices might be a little bit higher than the cheapest prices that you might see in the supermarket, but they're not wildly different. But then if you imagine how much a 2.5 litre bottle of 7.5% cider, which you can often buy for less than a fiver, 18.8 units in that, £12.22 under a minimum unit price. So minimum unit pricing has a significantly different impact on different products, but in particular, white cider, which is a huge problem because it's so cheap. Right. And I think it's also important to recognise that at 65 pence a unit, again, just to indicate, the minimum unit price for a pint of 4% beer would be £1.48. And so MUP has no impact on the prices of pubs, right? If you're buying a pint of lager for less than £1.48, I want to know where you're drinking. So anyone who tries to make an argument that this is a pub issue is disingenuous, right? This is a cheap alcohol in supermarkets and off licenses issue. So why does it work, right? That's what it does, but why does it work? Well, MUP only increases the prices of the cheapest alcohol because it's just setting a floor price. And we know that cheap alcohol is bought disproportionately by heavier drinkers, right? So this graph here just shows you the average price paid, so the average price paid per unit for different products by people drinking at different levels. So moderate drinkers, the green bars, that's people drinking within the guidelines. Increasing risk drinkers are drinking above the guidelines, and higher risk drinkers, that's men drinking more than 50 units a week, women drinking more than 35 units. So they're pretty heavy drinkers. And you can see that there's this clear price gradient, right? The more you drink, the cheaper the alcohol that you buy, and that's particularly the case. You can see cider, right? That's where there's this big price gradient, because the kind of cider that moderate drinkers are buying tends to be quite different from the kind of cider that very heavy drinkers are buying. But you can see why, because we've got this price gradient, that's why minimum unit price that only affects the price of the cheapest alcohol is effectively targeting the heavier drinkers, because it's affecting the alcohol that they're buying. Right. And in particular, because MUP removes or makes the availability of cheap, high-strength alcohol, it very effectively targets the heaviest drinkers from the most deprived groups. And those are the people, as Bill just showed us, who are suffering the greatest harms from alcohol, while at the same time it has a relatively limited impact on moderate drinkers. Many moderate drinkers aren't buying any alcohol at very cheap levels, and those that are not buying very much by virtue of being moderate drinkers in the first place. And so this means that MUP contributes to reducing those significant health inequalities that already exist. And we've seen that happening in Scotland. This isn't just a theoretical argument, right? This has really happened in Scotland. This is the impact on alcohol-specific deaths in Scotland by decile of deprivation, and you can see that the biggest effect is in the most deprived groups, right? So, and these, like, it might look like these bars, these are all quite close to the dashed line, which is no effect, but the numbers are actually, like, big, so that's 40% reduction, right? So this is really important, right? We know the minimum pricing does reduce health inequalities, which is hopefully something we could all agree we want to do. And then that leads you on to the next question. Well, okay, so it works in Scotland. Would it work here in Northern Ireland? And we were commissioned to do some modelling work, which we published last year. It's on the Department of Health's website. It's biased, obviously. It's a fascinating read. It's quite long. Just look at the pretty pictures. But an important thing to say about this is, although we published it in 2023, it's based on data from before the pandemic and before the cost of living crisis, right? So bear that in mind. And I'm just going to give you some illustrative examples of what a 50p minimum unit price would. So essentially, this is what a 50p minimum unit price introduced in 2019 would have done. Okay, obviously, everything is more expensive now, so a 50p minimum unit price now would have less effect than these numbers. So we estimate it would reduce alcohol consumption by 3.2%, reduce annual alcohol attributable deaths by 6.5%, so that's 29 fewer people a year dying in Northern Ireland, and it would reduce hospital admissions by over 1,300, that's a 5.6% reduction. And all of that would save the NHS £2.2 million a year, and I'm sure that's £2.2 million a year the NHS could do something quite useful with to improve wider health. And like MEP is not some silver bullet policy that will fix all of society's ills, right? There are still challenges to the policy, and in particular, those challenges are the majority of the additional revenue, so when you increase the prices, right, there's more money being spent. The majority of that goes to retailers and producers of alcohol. Now, in some senses, that might make it politically easier to do, but, you know, that might not be what you want. And so there is potential to mitigate that by introducing some form of windfall or public health levy alongside the minimum unit price to try and recoup some of that additional money. And then the other really important thing to consider is additional support required for dependent drinkers. Right? And it's really important to know that the argument about alcohol policy always ends up being portrayed as if there are only two kinds of drinkers in the world. There's nice, well-behaved, moderate drinkers, and then there's those naughty, dependent drinkers. And so the policy debate just gets framed in terms of thinking about how policies will affect dependent drinkers. The vast majority of heavy drinkers are not dependent drinkers, right, and will change their behaviour, but you do need to worry, rightly, about what will happen to the dependent drinkers. And so some additional support for those alongside minimum unit pricing would be a sensible measure, I would argue. But, and I don't think this is something that doesn't get discussed that often when we're talking about minimum unit pricing, although minimum unit pricing presents challenges for people with dependence now, it's hugely beneficial in terms of reducing the pipeline of people into dependence, because if cheap, high-strength alcohol isn't available, that makes it harder and more expensive for people to become dependent in the first place. Right? So it can have a significant future benefit. Right? It's not going to solve, right? It's not going to prevent everyone from being dependent, but it is going to reduce the number of dependent drinkers in the future. So, to summarise, minimum unit pricing removes cheap, high-strength alcohol from sale, while leaving the prices of more expensive shop-bought and all pub-bought alcohol untouched. And both modelling evidence and evaluation evidence shows that it's effective at reducing those health inequalities. But it's, you know, you don't necessarily have to consider it in isolation. Other policy options alongside minimum pricing can help to complement it. I think that's the end. There you go.
Wow, lots to take in, Colin. Thank you so much for setting the scene and giving us such a clear explanation of MUP as a policy and how it works in practice. Next up, you'll see him there, Dr. Roger McCrory, who has been a consultant hepatologist at the Royal Victoria Hospital since 2014 and serves as alcohol lead for the Belfast HSE Trust. He specialises in alcohol-related liver disease and has contributed to the NI Alcohol Use Disorder Care Pathway. Dr McCrory has also chaired the Treatment Support and Advisory Committee for the Department of Health. So you're very welcome today. Thank you.
Thanks for the introduction, Joe. So, yeah, as Joe was saying, I'm a hepatologist. So hepatologists are essentially doctors of liver medicine. It's a career you wouldn't get into unless you have a lot of empathy for people with alcohol dependence. It's certainly not a career every doctor would choose. And we often are seen by our colleagues in other specialties as de facto alcohol experts in the hospitals in which we work. And not only do we look after patients with alcohol-related liver disease, but we look after patients with other forms of alcohol-related harm. So it's hard for me to give a talk about liver disease without drawing your attention to this chart. It basically displays a standardised mortality rate for the 10 leading causes of death in the UK over the last 50 years. And you can see that all causes of death are downtrending apart from liver disease deaths that are increasing year on year and in fact have increased 400% in the last 50 years, which is really alarming. A lot of this is related to cultural changes in how we consume alcohol, its accessibility and its affordability. And there's a few important points to tease out. As Bill and Colin have already described, there's a very close association with social deprivation. So we tend to find patients patients in the lowest socioeconomic group are 4 or 5 times more likely to suffer an alcohol-related liver disease death than patients in the highest socioeconomic group. And the other important factors are that case finding is a significant issue for us. So many of these patients, not all of them, but many will be chaotic. They don't engage with healthcare in conventional ways. They may not attend their GP. They often won't attend outpatient appointments. They present in crisis to our hospitals, to ED, seeking admission, and they then often have quite protracted courses in hospital. And one of the striking things when NCPOD looked at this over 10 years ago was that of patients who died of alcohol-related liver disease, 71% were only diagnosed on their final admission to hospital. So we're talking about people who are only being identified at a point when they've got end-stage disease. We're struggling to identify these patients, and we're struggling, and often they're not aware that they're potentially drinking at a harmful level at the point they present. And when we talk about liver disease, these are the typical things that we tend to encounter. So often the patients will be jaundiced, some of them markedly jaundiced, and this is often attributed to a presentation known as alcoholic hepatitis. In the middle slide, you can see a patient with a very distended, swollen abdomen. That's because of fluid collection known as ascites. Whenever a patient develops ascites, they're looking at a 50% 2-year survival, which is really very grim. And the final slide is just demonstrating varices in a patient's gullet, their esophagus. So varices are like enlarged veins, varicose veins that line the gullet and the stomach in patients with advanced liver disease, and these can rupture and bleed. The patients present with vomiting of blood, passing blood in their stools. And if you present with a bleed from varices, there's about a 10% risk you won't survive that admission to hospital. So these are very, very sick patients that we typically encounter. And I think also important for me to flag with you that although patients who die of alcohol-related morbidity tend to die of liver disease, it only is a small proportion of the alcohol-related harm we see in our hospitals. So about 8% of patients presenting to our hospitals have alcohol-related liver disease. And you can see from this pie chart that there is a wide array of harm that is caused by alcohol, about 70 different conditions that are directly attributed to alcohol-related harm, and it impacts pretty much in every specialty in our hospitals. So we're talking about traumatic injuries, falls, assaults, the association with mental illness. We're seeing increasing numbers of patients with alcohol-related brain damage, There's about 6 forms of cancer that are directly associated with alcohol consumption as well. So we're seeing really large volumes of these sort of patients presenting. And I thought, just to sort of illustrate to you where I see the value of minimum unit pricing, I'd take you through a couple of pen portraits of typical patients we encounter. The first patient is a guy called Sean. Sean drinks 9 litres of cider a day. None of it has ever seen an apple in his life, as he'd tell you himself. He's probably drinking over around 400 units of alcohol a week, which is really extraordinary. He's had 7 admissions to hospital in the last year. He lives alone. He's socially isolated, estranged from his former partner, doesn't see his 10-year-old son. And on his most recent admission, he was found by the PSNI in a home who had completed a welfare check because no one had seen him for days. On admission, he spent about 8 days in intensive care. He had liver failure. He had very profound alcohol-related brain damage. When he made it back to our ward, he was bedbound, immobile. He was so weak that he couldn't swallow, he couldn't communicate. And we have a great team, and a number of our allied healthcare professionals were involved in his recovery. He had to have a feeding tube placed to administer nutrition. Strikingly, a lot of these patients will prioritise alcohol over eating, and many of them will tell you they haven't eaten for weeks. So they get all their calorie content from the alcohol that they're consuming, and you can appreciate the vitamin deficiencies that arise as a result of that. So basically, as Sean recovered, he had to relearn how to walk, how to talk. The speech and language therapists were involved. The dietitians were overseeing his nutrition. He saw occupational therapists, physiotherapists who helped him demobilise again. He met with our substance misuse liaison nurse as well. Over the course of the admission, I think he had about 25 x-rays, 7 CT scans, and MRI scans. So it just gives you a flavour for how these patients consume healthcare resources. And as he became more mobile, he was remained very confused, but would become agitated and aggressive. And the impact that has on nursing resources in our ward is really quite enormous. It's very distressing for other patients on the ward. You can imagine how terrifying it must be if you're unwell yourself and someone is behaving aggressively around you. And also, often these patients will need specials, so they need a nurse, usually a healthcare assistant, to sit with them 24 hours a day, to monitor them, to supervise them, to make sure they don't harm themselves or other patients. Ultimately, he made a very steady but slow recovery over several months, to the point where he regained capacity and was able to make decisions for himself. We had hoped to send him to the Leonard Cheshire alcohol-related brain injury home that has been running for the last 4 years in Belfast, which has shown some outstanding results in supporting these patients returning to independent living and maintaining abstinence. But unfortunately, they had no capacity, and ultimately, because he had capacity to make decisions for himself, he elected to return to his own home. And I'm afraid to say he's already relapsed back to drinking, and he has presented again with alcohol withdrawal within the last month. So you get a sense for someone whose fate is sealed in many ways. Like many patients, he hasn't been prepared to engage with the psychosocial support on offer, AA, community addictions team. And the value here of the minimum unit pricing is that we know this man is probably not going to stop drinking, but if we can get him to drink 200 or 100 units of alcohol a week rather than 400, then he's less likely to suffer alcohol-related morbidity, and there will be massive harm reduction for him, and also he's not going to have the same impact on healthcare resources he would have otherwise. The next patient I was going to tell you about quickly is Nikki. She's a 25-year-old girl. She's been drinking a litre of vodka a day for at least 10 years. In her case, the alcohol issues are intergenerational. Both her parents are alcohol dependent. She, as well, has had at least half a dozen admissions in the last year. We've met her several times over the summer with alcohol-related liver disease issues, and her latest admission, she's come in profoundly jaundiced. Her mark of jaundice in her blood, her bilirubin, was at 1.600. everyone in this room probably has a bilirubin of less than 20. So it just gives you a sense for how sick her liver is. And just over time, with supportive measures like giving her feeding through a feeding tube, she is now showing signs of recovery. She was actually given steroids initially in the hope that that would accelerate recovery, and she didn't respond to steroids. And when we see that, we're looking at a 25% 6-month survival. So we're talking about conditions that have worse survivals, worse outcomes than most forms of cancer, which is shocking, and strikingly young patients often as well. So I fear for Nikki as well. I suspect she will relapse on discharge, and often we see this revolving door policy, what we call these frequent flyers, who are not engaging with psychosocial support. They're not motivated to stop drinking, and they continue to represent to our hospitals with alcohol-related harm until ultimately they die as a consequence of that, which is very sad. And we have an excellent team. There's a lot we can offer these patients, but often they're very broken individuals, and we can't fix the social issues that underline the alcohol-related harm. So I think, from my point of view, the minimum unit pricing, as Colin has described, is not necessarily a panacea, but it does potentially offer a great deal of value in terms of reducing the amount of alcohol these patients will consume and reducing the accessibility of alcohol as well. And that's where I see the value. And I think, in turn, that should lead to, we've already, as Colin described, lead to a downturn in mortality and also admissions, particularly in the lowest socio-economic groups who will be most impacted by the minimum unit pricing. Thank you.
How do you follow that? Thank you so much. Thank you so much for the job that you do. I'm sure everyone in the room would agree with me. And thank you for giving us a clinician's view on what we're talking about today, and leaving us in no doubt about the gravity of the health and the mortality impacts of alcohol. Hearing about Sean and Nikki is hugely distressing, and something that I know will stay with me actually long after today. So thank you. Next up, please welcome Alison Douglas. So Alison, by way of introduction, she's come from Scotland, Chief Executive of Alcohol Focus Scotland since 2015. She advocates for effective alcohol harm reduction policies, including Scotland's MUP. Previously, Alison was head of alcohol policy and delivery at the Scottish Government, where she developed Scotland's national alcohol strategy. She's also a member of the Poverty Truth Community and an honorary fellow of the Faculty of Public Health. We're very glad that you're here today, Alison. Thank you.
Thank you so much. What a privilege to be here with you today. I think I was here about 12 years ago in my capacity as a civil servant, speaking to ministers about what at that point was an aspiration in Scotland to have minimum unit price as part of a wide-ranging alcohol strategy. So to come back and tell you about what it's achieved in Scotland and what some of the learning is for Northern Ireland is a real privilege, so thank you for that. So there we go. And Colin's already talked about Frosty Jack's cider and Diamond White, some of these high-strength, low-cost products which minimum unit price has effectively eradicated from the shelves of shops in Scotland. So that's one indicator of success. But why did we pursue minimum unit price in the first place? Well, frankly, I mean, seeing the figures that Bill was sharing with us earlier, it's a pretty obvious choice, because when you have an alcohol problem of the scale that we have in Scotland, and you in Northern Ireland are kind of second in the UK league table, and at one point you surpassed us in terms of alcohol-specific death rates, you really need to be thinking radical. And when you look at the international evidence, it's really clear that price is a major driver of alcohol consumption and alcohol harm as a consequence of that. And we, simply put, did not have the option of alcohol duty. So we had to think outside the box. What else was available to us in terms of price levers, and minimum unit price came up as the best alternative option. But it does something different and complementary to tax. I won't get into that just now, but what we need is both minimum unit price and UK government. They've made steps in the right direction, but we need alcohol duty based on the alcohol content of products. So it tackles, as Colin said, the high-strength, low-cost alcohol that is favoured by the heavier drinkers. But I can't emphasise enough, it is not on its own going to turn the tide of alcohol harm. In Scotland, it was one of over 40 measures that we had in our alcohol strategy. And it absolutely needs to be part of that broader approach, a whole population approach to tackling alcohol harm. But its purpose was to reduce population level consumption, but particularly to target the most harmful consumption, or the harmful consumption amongst hazardous and harmful drinkers. It's really important to point out that its purpose was not to target dependent drinkers. So, let's shoot that fox up front. If that's what you're looking to achieve, minimum unit price is not going to achieve that. As Colin pointed out, you need to be thinking about if people are waking up in the morning and they're physically or psychologically craving alcohol, affecting the price is not going to change that behaviour. You need much more intensive ways of engaging with those people. But to be clear, in Scotland, 1.1 million people are regularly drinking above the low-risk guidelines. About 50,000 people are dependent. So if we can affect the behaviour of that 1.1 million, as minimum price has done, then we're really still achieving a great deal. A bit of a busy slide this, the timeline, but I thought it was helpful to point out that Peter Rice and others were involved in looking at what different pricing mechanisms might be available in Scotland, and came up with the idea that minimum price was the best approach for Scotland. As I said, it was part of a package of measures, not on its own, but it didn't get through at the first time of asking. So there was a specific bill in 2012 that focused on minimum unit price, and it was passed unopposed in the Scottish Parliament. Unfortunately, because of the actions of the alcohol industry, that political consensus was unable to be implemented for 5 years, went all the way to the UK Supreme Court. That's how badly the alcohol industry wanted minimum price not to be implemented in Scotland. And I think that's really important. The public health community, civil society is united around the benefits of this policy, but it threatens the alcohol industry, and they will fight tooth and nail to prevent it. We finally got to implement it in May 2018, but it had, as part of the legislation, a sunset clause, and what that meant was that a thorough evaluation had to be undertaken, a report submitted to Parliament, and then Parliament had to decide, did they want to make this policy permanent, which it now is, and did they want to adjust the level of the policy, which, as of next week, will be increased to 65 pence per unit. So I mentioned that this sunset clause meant that there had to be a really thorough evaluation of what the impact of minimum unit price was in Scotland. You'll be very relieved to know I'm not going to take you through 40 plus studies, but I think the important point is that there was a theory of change behind how minimum price would work. So it would affect the price, that would therefore affect levels of consumption, and affecting levels of consumption should then lead to reduction in harm. And spoiler alert, what the evidence shows is that it worked in the way that was predicted. So just very briefly, the impact on our kind of national statistics. These are the things that we routinely collect, the sort of thing that Bill was talking about up front. In terms of alcohol-specific deaths, the vast majority of which are alcoholic liver disease. So these are conditions that are only caused by alcohol. There was a reduction of over 13% of those deaths. And you'll see further down that when we look at the wider range of deaths, there's an additional effect on things like alcohol-related cancers, alcohol-related strokes, etc. So it's had a massive impact in terms of deaths and also in terms of hospital admissions. And the effect has been seen disproportionately amongst those who suffer the most harm. So that's men and it's people in our more deprived communities. And I find this the kind of most convincing piece of evidence really around the impact of minimum unit price. As I mentioned at the top, Scotland has the unenviable position of being, the worst place for alcohol-specific deaths. And you can see from this that the impact of minimum unit price in terms of comparing alcohol death rates in Scotland with England shows that since it's been implemented, that ratio has reduced. So it was up around 1.9 consistently over a number of years. We're now down at 1.6. So when people say it's just modelling, it's not real world data, that's absolutely untrue. This is the real world data. And as I say, that impact on harm is because of the reduction in our levels of consumption. And you can see that the impact is disproportionately on those who are drinking above the low-risk guidelines. So people who are drinking below those low-risk guidelines, moderate drinkers, are barely affected by minimum unit price. And the flip side of that is that the evaluation looked at, are there unintended negative consequences from minimum unit price? And really, there are no significant unintended consequences. No increased use of drugs amongst people who were using drugs before or people who weren't. People have not been going en masse to England to buy their alcohol. There's no impact on crime. People talked about folks stealing alcohol because of the increase in price. No evidence of that. Or turning to illicit alcohol. That's not happening either. So the impact is vastly positive. What we do need to take account of, as I said, is about dependent drinkers. And we need, and this has been a failure in Scotland, really, to address the needs of that cohort of people. And we need to be taking that much more seriously. And finally, despite all the arguments of the alcohol industry, there's no evidence of a significant impact on them. Anecdotally, it's clear that the producers think that the retailers are making more money out of minimum unit price, but actually getting any figures on that is very challenging. And I think just to kind of point out that you need to be quite thoughtful when the alcohol industry is telling you what an existential crisis population-level interventions are. There were some wildly exaggerated claims about how minimum unit price would kill Scotch whisky, and none of it's proven to be true. So, in conclusion, what we've learned, it works. It achieves the stated aims of reducing consumption and harm, reduces inequalities, has little impact on moderate drinkers or on the on-trade. Dependent drinkers need additional support. You have to build in a mechanism to uprate it. Next week we go from 50p to 65p. That sounds like a hell of a jump, but it's, after the policy's been in place for 7-8 years, So in order to avoid that, what you need to ensure the effectiveness of the policy, you need to have it linked to inflation. And I'm not going to get into the other points. We can pick those up in discussion, but don't see it in isolation. It has to be part of that wider package. Thank you.
Okay, thank you so much for telling us about your experience of MUP policy in Scotland and giving us that snapshot of results to date. It all sounds very positive indeed. Next up, could we welcome Alex Bunting? Alex is Group Director of Therapeutic and Wellbeing Services at Inspire. Alex has over 20 years of experience in mental health and addiction services, and he is currently leading Inspire's wellbeing therapeutic programmes. He's held senior roles in addiction and mental health, advocating for recovery and support. And Alex focuses on delivering wellbeing solutions for workplaces, students and specialised groups such as veterans and police. Welcome, Alex.
Just before we start, I just want to say intermittent fasting, so my stomach might talk more than my mouth. Other thing to say, on my way here this morning, a trampoline blew out of my back garden into the school. I went to get it in my suit, fell down, covered in muck, forgot my glasses. It's the only thing that I've came to a Stormont to talk about alcohol, where I actually was tempted to go and have alcohol before I came. So, it's brilliant to see so many familiar faces here. A lot of people in this room have actually been advocating for and pushing for changes in alcohol legislation for many years. It's good to see Roger here. Me and him are going to the same hairdressers these days. So, and it is just to say, we don't do that enough, but many of the people in this room make a difference every day in treatment services. There's a huge amount of work goes on to keep people well, and this is part of a puzzle and part of a solution, but not the total solution. So, here we're an all-island charity, formed 65 years ago by Lady Margaret Wakehurst, who was a lady who advocated for her son to have mental health services. I very much follow in those footsteps many years later with colleagues, advocating for and fighting for services to try and make real change in society today. We have 68 services across Ireland, as you can see. 65 years of experience. I haven't been there from the start. I joined about 8 years ago. And also 42 years of experience in working with addictions. And it's been an important evolution for Inspire to adopt addiction services and bring addiction services in and under our mental health services because of the close links that we see with dual diagnosis and the impact that addiction has on mental health and mental health also has on addiction. And that's an important link for us to remember. In relation to the work that I now do, we do cover probably most of the people in this building in relation to their workplace well-being, and we see significant problems with alcohol consumption in workplaces and the impact it has on absenteeism, presenteeism, and it's a huge amount of resource required to motivate people back and support people back into work. And we're also currently dealing with Freshers Week in Belfast, which is interesting in itself for all of our staff. So what are we saying? I suppose one thing I could ask, if you have or know someone who's been impacted by alcohol or alcohol-related harm, stand up. Okay. That's the reason we're here. Okay. 77% of people in Northern Ireland drink alcohol, and we know, a bit like our Scottish colleagues and colleagues from Wales, that alcohol has a significant impact on society. And it really does remain the biggest impactful drug across the globe. And it is a drug, and it's about remembering that it is a drug when we talk about alcohol. In relation to the statistics around liver disease, we see that 70% figure in relation to deaths. And there's 356 preventable deaths. Let's note that they're preventable. In relation to mortality, and we talk, and I'll probably underline this, there is a real issue in Northern Ireland around deprivation and how we deal with deprivation. There is a significant amount of work required to address poverty and the impact of poverty in this country. Health inequalities are widening, and you can see significant impact across most of the communities that we work and support. And it doesn't sit in isolation from some of the impact that we've been through as a country, with 118,000 adults meeting the criteria for post-traumatic stress, which is 8.8% of the population. And we see the fallout of that in the work that we have with veterans, with the PSNI, and with many of the professions across Northern Ireland, as well as the communities that had the greatest impact. There continues to be an absolute lack of appropriate mental health treatment and services. Some of the access points at the minute would indicate 4-year waiting lists for psychological support inside NHS care. And we know that there's significant waiting times of waiting lists within community addiction teams and even the services that we provide and support in the community. So the context for me, we had a significant delay in commissioning. Some of that delay was actually down to the delay in this big house that we're sitting in, and some of the political fallout from that. Not a lot moved in a long time, and it is a time now for us to move and move at pace. Policy development hasn't always been where it should. We haven't followed the evidence like Wales and Northern Ireland or in Scotland have. We could have made this decision many, many years ago if we had the political will and the leadership to do so. We also had things misaligned. So, for example, huge investments like the impact of alcohol, 25 million from the big lottery. We probably had more pilots than Belfast City Airport in Northern Ireland when it comes to developing services. And none of that was lined up with our commissioning frameworks. So a lot of those services fell and weren't picked up. So we lose all of the traction that we had previously. In relation to the substance use strategy, we think it does have limited scope. And the big issues that we currently see, the mental health strategy 3 years on, is currently running at about £250 million underfunded. So we can write the best strategies in the world. If we haven't got the resources to put into those strategies, it really won't matter. So there's a lot of work to do in relation to securing resources. In relation to spend, one of the things we would definitely advocate for, and it is a problem, is the percentage spend we have here at Stormont that is directed towards mental health services. 100% of the health budget, World Health Organization would indicate a country of this size, scale, stature should be getting around 10% direct towards mental health services, which then fund our addiction services. We need to see that number up at 10%. As a minimum to try and address some of the significant issues and backlog we see in systems, waiting lists and everything else. It isn't a pretty picture, and people who know me, I've worked and advocated for people on the ground in Northern Ireland for many years, and it is those who live in the most deprived, highest impact areas that actually cost and pay the price and usually end up in hospitals or prisons. But when we look at all of those together, it is pretty stark. And when we look at things like suicide, 60% of suicides, substance misuse is a factor. Alcohol use is in there as well, so it's not just suicide alone. There is alcohol and drug influence there. So the cost of alcohol here used to be about 1/10 of the block grant. It's probably a little less now, but you can see the main blocks that we're getting impacted by in terms of our healthcare, our criminal justice system, our social services. And I would say you probably get, Joe, you could get the news down to about 15 minutes if there was no alcohol in Northern Ireland in relation to the things that are reported every night and their links to alcohol. So it has a significant impact right across our society. So is it part of the solution? It absolutely is. We have a dysfunctional ingrained behaviour here and on the islands. Good friend of mine who's passed a fair while ago now, Janet Coleman, used to do alcohol support for civil servants, and she would have joked, an old Terry Wogan joke, what's the difference between an Irish wedding and an Irish funeral? There was one less drunk. So you could see that culture, and we also compete with people, we're on holiday, we can drink more than the Scots, we can drink more than the English, and we have a dysfunctional culture. And that is inherited. We do have a binge drinking culture. Anybody who was out last night in Belfast looking at freshers, you can see there's a younger generation population there, and also being targeted by licensed trade. And there's some progress with young people, and I think Bill indicated that earlier. We are starting to see gym generations, coffee shop generations, and having an impact on that younger generation, which is brilliant. But there is a proportion of people, middle-aged people, generally men, who are really, really struggling in relation to those 356 deaths. And I suppose the most stark figure is that 45% increase in deaths since 2012. That's a huge figure to consider in relation to the impact in this country, and also the people who are missing around tables linked to alcohol use. So, industry, interesting that it's a highly lucrative business. It's why the lobby is so strong at Westminster and other institutions. They have massive budgets. Their advertising budget alone is said to be between 1 and 2 billion. But it's worth £66.8 billion to the UK, which you can see why it's so important. Problematic use is not their problem. I don't agree with that. I think the industry has a massive role to play in this. And if they would actually engage with people and we could actually see how they could best fund and help. One of the things we would like to see is actually a treatment tax, money going directly from alcohol sales direct to treatment organisations and hospital institutions to try and bridge the gap and also invest some of that in prevention work. In terms of those resources, with the strategies being delayed and prevention, to be fair, there is no significant prevention strategy in Northern Ireland. It's not joined up. It doesn't feel joined up across departments at the minute. And we hope that the new substance use strategy can bring more impact when that embeds itself. And then, is there a need for a direct tax? So our opinion, the business case is there. We're sold. Inspire firmly believe that minimum unit pricing needs to be embedded in Northern Ireland. Our service users don't agree. Our service users think this is a tax on the poor. One of the things that they really disagree with is the additional revenue that's generated is going to the retailers. And that really is a bugbear of theirs, that when we increase these prices and that goes to the retailers, they're the one who benefits from the minimum unit price going up and not going in, for example, to help and support communities. Inspire believe that the introduction of MU provides a clear message from government, and I suppose it is about that leadership role. It is a shift in policy. It is an indication that this is a powerful drug and it's having a massive impact on society. But it also, and it needs to be part of a plan, and that plan needs to focus on prevention, intervention, and, I may say, recovery. One of the things that we don't focus on enough is recovery services, keeping people well after they have been unwell. So what next? We would call for policy reform, definitely the implementation of minimum unit pricing. We want to see those focused plans on prevention. We want to see increased resources in terms of the mental health spend. And we also want to see an anti-poverty strategy because of the close links to deprivation. One last thing to just consider as a final thought. The UK tax revenue brings in 12.6 billion. The impact of alcohol is 27.2 billion. Who's paying for the gap? Okay. Thank you.
Certainly food for thought there. Thank you so much for your perspective from the coalface, Alex. Next up, our final speaker today is Dr. Joanna Purdy from the Institute of Public Health. Joanna specialises in alcohol, tobacco control and breastfeeding policy. She leads health impact assessment work and has contributed to alcohol policy consultations, including MUP. Joanna also supports the North-South Alcohol Policy Advisory Group in communications and knowledge dissemination. So, welcome, Joanna.
Good morning, everyone. It's a pleasure to be here, and I'm delighted to see so many familiar faces in the audience. And thank you so much for coming and supporting this event today. We've heard insights from those who had a very active role in informing and influencing policy and legislation in Scotland and successfully bringing forth minimum unit pricing of alcohol. We've also heard from colleagues in Northern Ireland on how necessary this policy measure is to reduce alcohol-related morbidity, mortality, as well as easing those pressures on acute hospital services and community-based addiction services. A core function of the Institute of Public Health is to inform evidence-based policy making in Ireland and Northern Ireland. And as part of our remit on North-South working and alcohol policy, IPH chairs the North-South Alcohol Policy Advisory Group, which was mentioned at the opening of today's event. This group was established by the Chief Medical Officers in Ireland and Northern Ireland in 2013. And one of the first outputs of that group was a paper entitled Reducing Alcohol-Related Harm by Addressing Availability, Maximising the Benefits of North-South Working, North-South Cooperation. And this paper identified alcohol affordability as a key driver of consumption, and that's a point that has been made a few times this morning, and noted that MUP was a valid intervention for reducing alcohol consumption and alcohol-related harm. In the years following, the respective departments of health in both Ireland and Northern Ireland consulted on MUP as a policy option, and the Institute has responded to those consultations, giving its support to MUP as a valid policy measure. MUP was then subsequently implemented in Ireland, as you know, as part of the provisions of the Public Health Alcohol Act in January 2022. Alison made the point that price is a key driver for alcohol consumption and the harm that it causes, not only to individuals, but to families, communities, and wider society. We have Eric Carlin in the audience today, and Eric has worked for the WHO, and one of their reports in 2022, which was entitled No Place for Cheap Alcohol, really highlighted that alcohol policies are the most effective and also the most cost-effective measures for reducing alcohol consumption and harms. The World Health Organization has emphasised the potential for MUP to be used in combination with other complementary policies, again, to address alcohol-related harms. We know from the work in Public Health Scotland, and I don't want to overlap too much with the statistics that Alison has already presented, but it's estimated that sales have reduced by 3%, with the greatest reductions among those products that increased most in price. We also know that households that bought the most alcohol before MUP reduced their purchasing the most after MUP was introduced. Again, we've heard the figures in relation to the deaths, the reductions in deaths and hospital admissions, with alcohol consumption itself reduced by 13.4%. Deaths directly caused by alcohol consumption reduced by 13.4% and hospital admissions by 4.1%. And the overall conclusions from the Scottish evaluation was that the evidence points towards MUP having had a positive impact on health outcomes, including alcohol-related health inequalities. The focus of today's discussion is about the potential of MUP for Northern Ireland. We've heard from Bill about the drinking patterns amongst adults and young people, as well as the extent of alcohol-related deaths and alcohol-related morbidity in Northern Ireland. We've heard from Roger at the very core, at the very heart of it, the impact of alcohol-related liver disease and the very serious effects it has on health, and very sadly, often resulting in death for many individuals. But as I've just mentioned previously, it doesn't just affect the individuals, it's the families, the children, it's wider society that's also impacted by these harms. And just for a few moments, I just want to kind of reference some of those harms, particularly the ones that children experience as a result of perhaps parental alcohol misuse. And in fact, the North-South Alcohol Group in its early days also had a subgroup that looked at hidden harm. And that particular group, with the Public Health Agency and the Health Service Executive working together, developed very valuable resources for professionals who come into contact with children to help them identify some of the issues and spot some of the harms that children might be experiencing. But just to highlight some of those for a moment, the harms often begin before the child is even born, with the risk of fetal alcohol spectrum disorder, where there's high consumption of alcohol during pregnancy. There's also the potential for parental care and family routines to be disrupted. There's an increased risk of emotional and physical neglect or abuse amongst children, but also amongst other adults living in the same households. Children living in households with parental misuse are also likely to be living in poverty, and we know that's a really, really significant issue in terms of the health inequalities experienced here in Northern Ireland. Children can often be separated from their parents, and there can also be changes in caring arrangements and even children having to take on caring responsibilities themselves. So this has a huge impact on families. There's also the risk that children may indeed engage in early substance misuse because of what they're seeing and experiencing at home. And again, just to reflect on the financial strain that this puts on families, not only is there a strain because of money spent on alcohol, but potentially other substance use, gambling, tobacco and drugs as well. In addition to the many harms experienced by children, we know that alcohol misuse has a significant impact on wider society. And again, Alex touched on those social harms and the costs that have been estimated in Northern Ireland. And we know from that 2010 report by the Department of Health that harms lead to additional GP visits, additional in-hospital, longer in-hospital hospital inpatient stays and outpatient visits to hospitals as well. There's an impact of alcohol-related crime on policing and social and criminal justice, as well as demands on emergency services, absenteeism from work, unemployment and premature mortality among the working age population. We know that overall these cost Northern Ireland society around 900 million per year, with up to 250 million of that directly borne by the health sector. The case for MUP has been presented today based on the evidence and experience from other jurisdictions. A comprehensive programme of evaluation is central to the implementation of a pricing policy such as MUP, and that has been very clearly presented for us today based on the example of Scotland in particular. I don't want to repeat some of the pieces that Alison has already mentioned, but we know that that comprehensive programme of evaluation looked at the implementation as well as compliance, public attitudes, how the industry responded, and the economic impact. However, there are challenges to evaluating MUP, and perhaps the most significant was really around the timing of the implementation of the policy, both for Scotland and Wales. We know that Scotland was about 2 years or less than 2 years into MUP when COVID hit. And for Wales, well, perhaps Will can tell us a little bit more about that. 3 weeks after the Welsh Government announced the introduction of MUP there, we had a national lockdown introduced. So really significant impact on some very, very important policy measures. But as well as that, we know that drinking patterns changed significantly during the pandemic. We had changes in terms of the unlicensed sector being closed and the off-licensed sector remaining open. There was also impacts in terms of data collection, with face-to-face interviewing being suspended, surveys moving to telephone versions, and even surveyors being more restricted in terms of the number of questions that could be asked. So all of this has had an impact on data collection. Nonetheless, we still have an amazing evidence base for MUP. The Institute, along with the North-South Alcohol Policy Advisory Group, has developed effective working relationship with these colleagues and established research partnerships with the devolved nations. The North-South Group provides a valuable forum for sharing and learning resources, particularly in relation to national policies such as MUP, which is why we can bring you all together today. In closing, I would just like to commend the excellent but often arduous work that has been undertaken to implement MUP. It clearly hasn't been an easy journey, particularly with the lengthy legal challenges in Scotland, but there is no doubt that the work undertaken by the other countries has certainly paved the way for implementing minimum unit prices in other regions, and we know it's a measure that saves lives, improves lives, and helps reduce alcohol-related health inequalities. Thank you.
Okie dokie, thank you so much. Now, your turn. We've got about 20 minutes or so before we break for lunch today. So I'd love you to speak to our panellists today, share your thoughts and questions. And if I could invite the panellists, please, back up to the stage, that would be great. There's a roving mic, so please, if you want to just tell us who you are, where you're from, and pose your question, that would be great. Okay, there's a hand up already. Thank you so much.
Hi, Thank you to the presentations and the presenters. Really fantastic and very informative morning. My name is Una McKinney. I've spent 10 years working on alcohol policy in Ireland, both in government and out of government, in terms of policy formation, legislative framing, and on the advocacy side. So a bit like a lot of people in the room, I have a lot of scars from the impact of the alcohol industry on my life. But if I could, very, very briefly, just a couple of questions, if I can. To Colin, perhaps I could I'm just curious, maybe just you might give us an oversight. This is more a technical question, I suppose, but seeing as we're here to talk about MUP, we might as well get a technical question in first. The value of the inflationary escalator as a policy instrument. I mean, we know we didn't do it in Ireland, you didn't do it in Scotland. What is the real value of attaching that escalator when framing policy and legislative framing? And if you can, perhaps maybe give us your economist insight into potentially the dynamic of that with an inflationary environment, that we're now living in. What is that likely impact on alcohol sales? My suspicion is that it's probably quite significant. And I think we've seen that in Ireland, certainly over the last 2 years since we've had an MUP. And then just very briefly, if I can, Alison, I just wondered, maybe perhaps you could just address the point about, you made a good really insight about the instigation of the sunset clause, which was really quite unusual, again, as probably a bit of a gift to the alcohol industry at the time, perhaps. However, in hindsight, my view would be that perhaps that sunset clause was actually quite useful. It did pose challenges. It certainly posed challenges to me at a time when I was occupying a lot of media time. But I just think that in hindsight it probably was a good idea in terms of really rigorously analysing what work this could do. And so I'd just be curious to know what your thoughts on that. And then very finally, just overall, to pick up on Alex's point and on Joanne's point, the point about harm to others. We know in Ireland there's 200,000 kids living every single day with the impact of parental alcohol misuse. And, to Alex's point, since 2012, you talk about 49% increase in deaths. I just wonder about that impact of the harm to others. And as Joanne alluded to, the early initiation of alcohol by kids, what the impact of that is. So thank you.
Right, Colin, can you remember that first question?
Yeah, so the point about inflation is really important. It's one that we tried to make to Scottish Government before they introduced the policy, but they decided to, because with the sunset clause, they would introduce it and leave it at the same level and then review it afterwards. But it's really important to think about, to have a plan for what to do, because if you just set the minimum price at a level and then forget about it, you see the same thing that the US has seen with federal alcohol taxes, where they just left them at the same level for years, and so over time inflation erodes them, and they just become less and less effective over time. And like Alison said, that Scotland's increase from 50p to 65p seems like a lot, but really inflation has been so high that it's not a lot, right? 50p in 2018 is worth about 41p now, and if you wanted to maintain the level, the effective level of MUP at 50p, it would need to go up to about 62p, I think. So actually 65p is almost just matching inflation. So it's really important there's some kind of plan, whatever that is. And I realise that there's kind of implementation issues about, levying it, pegging it to inflation every year, but whether it's every 5 years we'll review it or every 2 years or whatever, there needs to be some kind of plan, because otherwise you don't want to introduce it and then it just withers on the vine and you lose that benefit over time.
The Scottish Government had committed to review the price after 2 years, and that didn't happen. I think probably largely because of COVID, but also to Colin's point, actually the duration of the evaluation was such that, if you changed the price, it would have made it even more challenging, I think, to really kind of get a sense of the impact. On your question about the sunset clause, I think the sunset clause was really, really important politically, because minimum unit price was unopposed when it went through in 2012. But it was also really important legally because the UK Supreme Court talked about the fact that it was an innovative approach and that the government were kind of, it was reasonable for the governments to kind of take this measure to protect public health and to save lives. But the fact that they had undertaken to conduct such a thorough review was important in that legal decision. So I think for both political and legal reasons, it was actually really positive to have that sunset clause in place.
Joanna, any harms?
Yes, indeed. We know that 1 in 11 children across the island of Ireland are living with parental alcohol misuse, and as I alluded to, there are very significant impacts in terms of children's emotional and physical development, as well as the impact in terms of school attendance and the social connections that they have. And you're absolutely right to pick up on the point about the risk of early substance use as well, where children are exposed to high alcohol consumption in the home. That in itself is an influence, but as well as that, it's obviously giving children access to alcohol, and more broadly we know that the physical access to alcohol is obviously another driver of consumption, along with the price that we're talking about primarily today.
Okay, thank you. Yes, Lydia at the back there, please.
Thanks. My name's Claire Flynn. I work in public health in Belfast Health and Social Care Trust. I wanted to ask the panel what you think in a few years' time, when MUP is implemented, what might be the next bold policy steps we could take to address alcohol harm? And maybe not just in harm related to those people who have really chronic and acute issues that Roger talked about, but even those, harms that are perhaps at the minute going under the radar, like the increased impact on cancer numbers and cardiovascular disease and, productivity in the workplace. My ideas would be around maybe I'd love to see a public health campaign on the link between alcohol and cancer risk, which is in our substance use strategy and our cancer strategy, but no talk of it being implemented yet. And also maybe a ban on sort of those promotional multi-buy offers in the supermarket, buy 6 bottles of wine, get 20% off, and then you're at home and you've had a few glasses and you end up drinking more than you'd anticipated. I'm just wondering in the future, what comes next?
Yeah, I think Al actually said MEP is just part of the puzzle, it's not the solution. Do you want to pick up on that firstly?
Yeah, I think I'll just reinforce, we've worked for many years looking at this, from prevention the whole way through to recovery and things being joined up, and us actually tracking outcomes against policy reform. But there's a massive deficit here in this country around resources and directing resources towards targeting the issue. And we already know the issue is huge. So if we're disproportionately not funding the response, even public health messaging, is it joined up? Is it effective? How effective is it? Are we putting enough into it? Because these guys, the industry, are spending 2 fortunes working in the other direction, trying to get people to start drinking younger and drinking longer. We need to be as combative as that when we're getting into our solutions. And it does need to be that entry to exit into alcohol use. But I would actually prefer we really front-loaded money and try to prevent people, particularly in socially deprived communities, entering that sphere, because what we know is they struggle the most to get out of it.
Okay, thank you. At that point, can I come to Niamh? I'm going to point this on you, Professor Niamh Fitzgerald from the University of Stirling. Would you like to come in on that? I know you've been doing a lot of work on licensing.
Thank you. Hi. Yes, thank you. So I guess people have talked about the need for a kind of comprehensive strategy and the other measures. That's a great question. The other measures that you could bring in that don't cost money, and of course there's a need for resource for the things that do cost money and that really coalface support. But a lot of the measures that are effective don't actually cost a lot of money, if any, to implement. So if you look at things around licensing, I can't say too much about that. We've done a big review of the licensing system in Northern Ireland with my colleague James Nichols, and there's multiple recommendations in that report which will be coming out over the next couple of months. But if you look at marketing, for example, you've got big alcohol companies spending lots of money, as we heard, attaching alcohol to the things that people have emotional attachments to, like the football and gigs. and family events and Mother's Day and all of those things. And so the measures around marketing, there's multiple measures, but even if you just take one, and to pick up on the point about alcohol and cancer, the public don't have a great awareness of the link between alcohol and cancer. And you've got labelling, health warning labels coming in the Republic of Ireland around alcohol and cancer. My understanding is that labelling is technically a devolved issue. Health warning labelling is a devolved issue in the UK, and so there is, in theory at least, the possibility of Northern Ireland moving to match what's happening in the Republic around labelling. And when we speak to the public about that, they feel very strongly that they're not being told the whole truth about alcohol. So they look at over-the-counter medicines, and they look at cigarettes, and they look at other, products that are drugs, and they get lots and lots of information. Whereas, a beer needs to have less information on it legally than a zero alcohol beer does. There's no ingredients required, no calories, no warning labels. So there are measures there that don't necessarily cost money, other than legislative time to put in place, that could also be looked at.
Yeah, thank you. I think there's even a general lack of awareness about, we were talking, Suzanne and I, and with the team in work, about just what are the sensible drinking limits, what do 14 units a week look like for men and women. There's a bit of confusion there. I'm really interested, though, to come to you, Wolf, next, Professor Wolf Livingston, Professor of Alcohol Studies at Wrexham University, because I would like to hear about the Welsh experience and how, if at all, you kind of tracked what Scotland were doing and what obstacles you came up against.
Yeah, so I suppose it's interesting because we're second, so we're sandwiched between Scotland and what's happened in the south of the island, and as you've heard, we had a very deliberate approach. So we also have the sunset clause for all the same reasons that Alison said. So we've literally just put in the final overall evaluation, and that's being now discussed within, and that will get published in the next sort of 6 to 8 weeks. The deliberate approach in Wales was to almost hide in the shadow of Scotland. I'm not sure if that's the correct term to say, but we chose 50p because it could avoid the same legal challenges, sunset clause. So actually, we let the Scottish government, in a sense, and the people of Scotland, they took all the flack for that. They took all the industry, and therefore we didn't. So that was a relatively easy place to arrive at. In terms of evaluation, we deliberately set out on a route that said, what we want to do is to see, do we have the same echoes of what's going on in Scotland? We can't afford, and I'm sure Northern Ireland can't afford, to invest the huge amount of money that's invested in Scotland in evaluation. So we actually just look to see, have we got the same messages? And without prejudging or saying something that I can't say about what's published and is owned by the Welsh Government, there are no surprises in anything that finds in Wales. You'll see that in the 9 of 13 reports that are already published. The echoes are really, really strong. So, and that's no surprise, really, at some level. All the things that have been talked about. We had Frosty Jacks, and then we didn't have Frosty Jacks, and so on and so forth. So, it's comfortable to follow in that shadow. Yeah. It meant that there was less political exposure. The difficulty for us, and this may be some of the problems for Northern Ireland, is that we have, if Scotland don't quite have devolution max, we don't even have devolution light, we've got devolution skinny. So most of our powers are actually sitting in Westminster. We can't do the licensing things, we can't get rid of the multi-buys. So we have minimum, so just one final thing, so we have minimum unit pricing, for example, but whereas in Scotland they don't have the multi-buys because of some of the things that go on. If you go into the Welsh supermarkets, we still have promotional stuff, but the promotional stuff has to sit within multi-buys. So when it first came in, we had a whole set of beers that were 3.3, and they were the ones that you could buy the 3 for the £5 because that came all right. But the small beers that were on the shelf with 3.4 units, they crossed over 10.2 and they were out of the multi-buy. So you get all of that kind of stuff with the... So there is a devolution light experience that makes it more awkward. And therefore, in many ways, it makes minimum unit pricing even more valuable when you don't have the same armoury that either Scotland have, let alone the independence that comes in the south of Ireland. So it becomes more valuable because there's actually less available in that context in a funny sort of way. So something like that, yes?
Okay, thank you so much for that. I know that we're joined today by Dr. Peter Rice, Chair of the Institute of Alcohol Studies, and Alex certainly mentioned, and in fact I think all our panellists mentioned it, the link between consumption and mental health. So as a psychiatrist based in Scotland, we'd be really interested in your perspective on the impact of MUP on mental health, both at population level and among heavy drinkers.
Yeah, sure. Well, thanks again. Just to join others, say it's great to be at this event and to see it happening. Yeah, I mean, I think Alex captured it really well. We could spend all week talking about the two-way link between alcohol and other substances and mental health, and it's both cause and effect, and it's cause and effect within single individuals. So, but I think in Northern Ireland there are some very particular issues, I think, related to mental health. If you look at the UK-wide investigation into suicides of people in contact with mental health services, 20% of people who die of suicide in Northern Ireland have a primary diagnosis of an alcohol problem, an alcohol use disorder. So it's not depression, it's not PTSD, it's an alcohol use disorder. And that's quite a bit higher than other parts of the UK. So there seems to be a particular issue with alcohol and suicide in Northern Ireland, and alcohol tends not to get a very prominent role in suicide strategies, and I think that's something that really ought to be paid attention to. But I think the other important thing about mental health really was the pandemic, and Joanna mentioned this about, and Colin and others did too. The impact of the pandemic and the effect of that really emerged pretty quickly, or the impact of that, with this polarised pattern of most people cut back their consumption, but the heavy drinkers increased their consumption, and that drove up mortality, as Bill showed in his figures. And I think it's probably helpful to think of kind of two groups of those heavy drinkers. One will be the kind of distressed heavy drinkers who maybe have dependence symptoms and certainly know they're drinking too much, wish they weren't, but difficult early life and trauma, and are, their upward consumption was driven by anxiety and negative mood states, during lockdown. But I think the other group of the kind of relaxed heavy drinkers who, didn't have to go to work anymore, they didn't have to commute, their incomes were maybe protected, probably, wealthier people who had more opportunity to consume and tip over the edge and end up in Rogers Ward. So I think that and of course many of them will have then developed mental health issues on the back of their drinking. Their family would get annoyed at them, they get depressed about themselves, and it's a kind of negative mood state. So actually I think it's helpful to actually think about both the kind of stressed heavy drinkers and, if you like, relaxed heavy drinkers during lockdown, because I think both of them, lockdown had the effect of pushing up their consumption with the impact that we then see in mortality. And one very last thing to say is that's the reason why you'll still see some people arguing in Scotland, well, how come you're saying this policy has been a success when deaths are actually a little bit higher than they have been? And the answer to that was in Alison's slide, that compared to where Scotland would have been had we followed the trajectory of England or of Canada or the USA, where deaths are up about 40% in the last 3 years in those countries. Now, Scotland hasn't had anything like that. So, all of the stats work against a moving target, because things are changing, and so that's the relevant comparison. Okay. But yeah, I mean, the mental health impacts, I think, are very considerable, and the access to treatment, again, Alex described this very well, and I would fully agree with his comments that the alcohol's taken second place to other drugs in terms of treatment services. I know that Helen Toll and Joy Watson are here, who are both addiction psychiatrists in Northern Ireland, and I think alcohol's actually had a lot of trouble getting its place in space when there's been so much focus on other drugs, and that's the thing we need to actually start challenging and dealing with.
Okay, let me just come back to the audience, please, at this point. Any further questions? Yes, I'll go to this gentleman here, please.
Douglas Hamilton, consultant in public health and health improvement in Dublin North East area, which borders to Northern Ireland, as you know, in Louth, Cavan and Monaghan. So thanks very much for the invite. One of the issues that struck me was Colin's talking about the health economics of this, and then one of the last slides was that the costs outweigh the economic costs outweighs the economic benefits by, in the UK, something like 23 billion to 12 billion. And that, for an economist, is just not on. It sort of shows that we are not actually paying enough tax and levies on alcohol to try and balance that in a sort of Pythagorean sort of way. There was also talk about a levy, a retailer's levy, but I don't think Sheffield has really addressed that in a way maybe as much as MUP or MUP. And I wonder how, with those facts on the table, how do we put together a levy that would be effective that we could then use in terms of alcohol prevention and alcohol, sort of the social damages and harms that alcohol causes, to support that with the work, the sort of work that Alex is doing, and so on. So that's a question, as opposed to the economists. Really, how do we do that? How do we put in a retailer levy that could work?
Would you like to pick up on that?
Can I pick
Yes.
that up, Jo?
Yes.
Because it's something that Alcohol Focus Scotland and our partners are really actively advocating for at the moment, is a retailer's levy. And in doing that, we've got to deal with the challenge that actually the only people who know how much profit is being made are the retailers, right? And they're not telling. So we've got wildly varying estimates of the increased revenue, and we're talking about an order of magnitude of tenfold between Institute of Fiscal Studies estimates and Fraser Ballander Institute estimates. So we don't know how much more money that they're making, but we do know that they're very likely to be making additional profit. And fundamentally, that is unfair. And most members of the public assume that minimum price is a tax and that the additional money is going into the public purse. And really, absolutely, it should be, because, as you've said, these huge social costs of alcohol. So we're advocating for that. And again, we've had to make pragmatism, the kind of master of, an ideal state. So what we're advocating for, and I don't know if you can do this in Northern Ireland, but it's a levy on non-domestic rates on the retailers who sell alcohol, and that's what we're advocating for. And there's precedent in Scotland for that kind of levy. So we know we can do it in terms of legality and in terms of practicality, and we're saying that money needs to go locally for preventative activity and for supporting improved treatment and recovery support.
Okay, thank you. We're running very tight on time. I'd like to come to Dr. Eric Carlin briefly, please. Give us some context as to where alcohol harm in these islands stands in relation to other parts of Europe and the world.
Sorry, so I'm Eric Carlin. I worked until February this year with the World Health Organization on alcohol policy, and I'm now working as a consultant with the Institute of Public Health. High. I mean, we have the highest levels of consumption harms in Western Europe. It's related to culture. It's related to the fact that we have had alcohol marketed in different ways since the 1980s. We've had cheap alcohol. I was really interested in the discussion about kind of culture. Culture's changeable, and the alcohol industry knows that culture is changeable. In the 1930s, there was a Royal Commission that looked at Scotland and decided that Scotland did not have an alcohol issue. There was nothing to do on alcohol because the levels of alcohol consumption in Scotland in 1932 were so low that there was no need to be concerned about it. So I think culture is completely changeable. Can I just say something about the broader policy context? Because one of the things I had the great privilege to work on was the Alcohol Framework for Europe, which is WHO's strategic framework, which was adopted by the 53 countries of the WHO European region. So the UK government signed up to this as a framework for action. What that emphasises is a joined-up approach across all of the areas where you can have an impact and where there's really robust evidence. Pricing is the area where there's the most robust evidence in terms of impact in reducing harms, and taxation is the best of the best, but minimum unit pricing is another lever that can support taxation and other pricing policies. Action on availability, action on marketing are really important. Action on health messaging, labelling, action to improve health services, both preventative services and services for people who are getting into difficulties. But also importantly, within the WHO's framework, which, as I say, the government has signed up to with all the other countries, is a focus on community action. I think one person here mentioned recovery. I don't know if anyone else mentioned it.
It was Alex, yeah.
Okay, Alex, thank you for that.
Yeah.
I think it's so important that communities have got the solutions very often to the problems that they see on a daily basis, and they can steer governments to work out how best to implement policies on availability, policies on marketing, policies on pricing in those local communities, so the local communities will understand and therefore will support, because they'll see an impact happening as a result.
I think we could talk all day. Sadly, we've run out of time. Thank you so much for that. I'm going to leave the final remarks to Suzanne, but really interesting debate today. Thank you to all our panellists.
Just simply to say thank you to all of you for coming here today, giving up the time. I know everyone's very busy. I hope we can continue the discussion over lunch in a few moments. Just join us at the back of the room. But I'd particularly like to thank our panellists who gave up their time to travel here today to share their expertise, our expert guests in the audience. And I would like to particularly thank my colleague Adam and his team, who've done all the heavy lifting on this event today, because it's very difficult to put these events together and it looks very easy, and he's made them look very easy. And finally, I'd like to offer my thanks and a round of applause to Joe Scott, who's moderated the event so well today. So thank you very much indeed.